Assalamualaikum. Good afternoon. I would like to thank each and every one of you for being here with us at live session from MAHSA University, Saudara Putra campus. I am Muhammad Al Kausar bin Harun. I am from Faculty of Health Sciences, MAHSA University, and I will be moderating today's session. Today's webinar, How to Deal with Movement Dysfunction, is proudly organized by Faculty of Health Sciences, MAHSA University. Dear viewers, before we proceed further, I would like to give you a brief overview of the programs offered by the Faculty of Health Sciences at MAHSA University. Faculty of Health Sciences consists of School of Physiotherapy, Department of Environmental Health, and Department of Medical Imaging. School of Physiotherapy, we have Diploma in Physiotherapy, Bachelor of Physiotherapy, Bachelor of Physiotherapy ODL, and Master of Physiotherapy. For the Department of Environmental Health, we got Diploma in Environmental Health, the Bachelor of Environmental Health and Safety, Bachelor of Environmental Health and Safety ODL, Diploma in Occupational Safety and Health. For Department of Medical Imaging, we got Diploma in Medical Imaging, Bachelor of Medical Imaging, and Bachelor of Medical Imaging ODL. Why join health sciences? First, because we are essential service, high job demand, no boring work routine, lucrative remuneration, a career you can feel good about, opportunity to work in variety of settings, low risk of job redundancy. For Master of Physiotherapy, we got two types, full-time 1 year program and part-time 2 year program. And this is the entry requirement. These are the list of the bachelor program that we got in health sciences. First, Bachelor of Physiotherapy, Bachelor of Physiotherapy ODL, Bachelor of Environmental Health and Safety, Bachelor of Environmental Health and Safety ODL, Bachelor of Medical Imaging, and Bachelor of Medical Imaging ODL. So this is the entry requirement. And these are diploma program in our faculty. First, Diploma in Physiotherapy, Diploma in Environmental Health, Diploma in Medical Imaging. These are the entry requirement. So we also got Diploma in Occupational Safety and Health. It is a 3-year program. So these are the entry requirement. Why choose Faculty of Health Science MAHSA University? Teaching and learning, interactive teaching and emphasis on hand-on skill. We got face-to-face and also online platform, which is LMS. Wide list of hospital or institution for clinical and industrial placement. Also accredited by MQA and GPA with international recognition. Cross-teaching by expert. MAHSA has the most number of health sciences discipline in a single institution. Various study modes, we got conventional and ODL, and also we experienced and dedicated international pool of academic staff. So we also got a few scholarship, and we also have a collaboration and affiliation with this some of the collaboration we got. For example, MPA, which means Medicine Physiotherapy Association. And also here we got student mobility program. Here this picture regarding Aero Social University. We got student mobility. Our student will they go at there. And also student mobility program at Lovely Professional University. And also at Universitas Sriwijaya. We welcome you to join us. Okay, please contact us through MAHSA website or through our faculty Facebook page to know more about our program, or simply leave a comment. We will get back to you. Your question concerning this webinar session can be listed in the chat box. This webinar will focus on concept of addressing movement dysfunction. Movement analysis screening also will be taught during this webinar, and understanding the possible approach in rehabilitating a person with movement dysfunction. Before we start with the webinar, I would like to introduce our speaker. He is Mr. Bannister. Mr. Bannister is a clinical instructor come junior lecturer. He holds a Master of Physiotherapy and currently working as a lecturer in School of Physiotherapy, Faculty Health Science, MAHSA University. He also provides support as a clinical physiotherapist for MAHSA Physiotherapy Clinic at MAHSA Avenue. Without further ado, I would like to invite Mr. Bannister to deliver his presentation. Welcome, Mr. Bannister.
Hi, and first of all, thank you very much, Kausa, for that very humble opening and the introductions. Okay, so my name is Mr. Bannister, and for all of you may know, you can call me Ben. Okay, so like what Mr. Kausa did mention, I'm also teaching and also act as a support for the physiotherapy clinic in MAHSA Avenue. For all of you have any issue, you can come by at MAHSA Clinic. We have a good team. We have a decent place that you can actually look around and also have a look. Okay, so before I start, I'm gonna share myself the slides for today. Okay. So the topic for today is basically looking into movement dysfunction and how should we deal with it. So I suppose that some of you all may have already known about movement dysfunction, but what actually movement dysfunction is. And take please do not mistaken it with movement disorders. Okay, movement disorders is primarily in neurology, where you have disorders such as like Parkinson's disease, myasthenia gravis, and all of these things. So those are movement disorders like chorea, epitoid, CPs, and all. Those are movement disorders. Movement dysfunctions are primarily can be seen based on a dysfunction of a certain muscles, can be overactive or underactive. Also, there might be a poor functioning of your joints that creates a compensatory movement. Okay, so let's get into movement dysfunction. So let's dive in a little bit about movement dysfunction. So what is movement dysfunction actually? Okay, is there any definite definition for movement dysfunctions? Actually, there is none of it. Okay, so movement dysfunction based on Shirley Sherman's, it's actually a varieties of terms describe a painful musculoskeletal condition of unknown origin. We won't know where is the origin of these particular problems. Okay, so where the pain is may not be the problem is. Maybe the problem is originating from somewhere else. However, what you felt is a byproduct of that movement dysfunctions. Okay, synonymously being used as a movement impairment syndrome with MSP, musculoskeletal pain. Okay, and then this musculoskeletal pain is also again is a one big terms where we said it is an umbrella term. So under that umbrella terms of MSP, we have bunch and a lot of conditions such as your supraspinatus tendon or many pathologies, your jumper's knee, your osteoarthritis can also be one of those musculoskeletal pain. So it's a very broad terminologies, right? So, what is movement dysfunction again? So, here in this presentation, I will focus on four things. So, basically, focus on the dysfunction of peripheral neuromuscular and musculoskeletal system. So, movement dysfunction itself is focusing on this. And number two, it is focused on joint dysfunction also, because any issues with musculoskeletal, such as your muscles, your tendon, and other soft tissues, will lead to a joint dysfunction. So primarily from the soft tissue imbalance, it will cause a joint problem. Okay. And number three, also there will be a bit of a role in terms of central nervous system dysfunctions. So within this central nervous system dysfunctions, it's not in terms of neuromuscular, or sorry, it's not in terms of neurology in aspect, not totally in the same way of what when we are looking into strokes and other neurological condition, but neuromuscular condition in terms of the ability of your body to create the nerve impulses within a given time reaction, speed of reactions, all of that are neuromusculars. Okay, focus on movement system. Okay, so basically focus on movement system, everything that contributes to a movement, we are going to focus a little bit today. And also we are going to focus a little bit on the concept or the models on how can we determine what is movement dysfunction, whether are we treating a person with movement dysfunction or are we doing anything beyond that. Okay, so there is no definite prevalence in terms of movement dysfunction, because movement dysfunction again allocated to a lot of musculoskeletal problems. So if you look into this picture, it's why I use this particular photo. It's like an hard drive, so it encompasses of a lot of things. So when we take out one portion of it, if you look into the evidence of movement or evidence of musculoskeletal injuries per se, this one of these evidence is talking about Malaysian Hockey League players, which is based on Manaf. If you look into the conclusion of the study, most of the studies are actually each sports they have a pattern of injuries. Okay, like Malaysian hockey players, they have a pattern of injury towards their lower back and also legs, but not much on their shoulders. But why? Okay, so again, when you look into the another evidence of prevalence of musculoskeletal injuries among taekwondo players, they actually have more of a hip and also foot injuries. Again, what are these patterns telling us? Okay, again, for an expensive sports, equestrian, okay, equestrian, again, you will look at equestrian might have not much of injury, but what kind of injury do they have? They have they have actually a different kind of patterns of injuries, which actually may not be at the groins. It's different. Okay, when you look at it, they actually have more of a shoulder issue. Okay, when you look at equestrian, they are riding the horse, and we always assume that these kind of people will have actually a groin injury or maybe a hip injury, but it is not that likely. Okay, so we are actually looking into a lot of patterns. So each patterns of injuries may contribute to a certain problems. Again, if you look into Olympic weightliftings, okay, most Olympic weightlifting, when you look into these three big lift, which is your deadlift, okay, which is one, your bench press, okay, and also your squats. Again, in Olympic lifting, we have your clean and jerk, you have your snatch also, okay, which quite popular in Malaysia right now is where people are joining CrossFit. Yeah. So in CrossFit, we also do a little bit of snatch, clean and jerk, pulls, and all. Again, if you look into the systemic review of this particular shoulder injuries, okay, when you look into the conclusion, most of them are stating that these injuries of the shoulders will always highly correlate with a lower back pain. So what is the relationship? All right. Is there any relationship with our back and our shoulder? Yes, definitely. All right. But in schools, we are taught about a component isolatedly. Okay. So this is where I would want to empower everyone. This is what I want to share today. I just want to empower everyone that we should not look an injury based on an isolated whole. Okay, we need to look a movement at a whole. Right. So by doing so, we need to understand a few relevant models. Okay, so the first thing will be the pathokinesiologic model. So the pathokinesiologic model is actually focusing on interaction between individual components of body systems. So you have few systems in your body. You have your musculoskeletal system, you have your nervous system, cardiopulmonary systems, and much more. Okay, you have your metabolic system also. Okay, by understanding these secondary changes of each system, okay, we will understand what are the primary pathological effects of each problem. Okay, if I have an issue with my cardiorespiratory problem, okay, although I feel like I'm doing fine in lifting a certain amount of weight, but because of my inability to keep up based on my cardiorespiratory endurance, eventually I will not be able to lift a certain amount of weight. And it is not because I do not have the ability of my muscle strength. It is because my supporting system, basically my cardiorespiratory system, is not allowing me so. Okay, so with this, we will understand that each of that particular system plays a lot of roles. Okay, where you have your base system, which is your muscular and your skeletal system, which comprise of your muscles, your other tissues, and your bones. So you have your modular systems, those those systems that controls the movement and react to the movement. So that is your nervous systems who creates balance. Okay, your biomechanical systems, so your static and your dynamic movements. How fluid is your movement? How great is your sequencing of activations? Okay, and you have your support system, which is your cardiac, your pulmonary, and your metabolic system. So all of these systems comprise of getting a good musculoskeletal health. Okay, so with this, we drop down into an varieties in a specific joint movement and posture. Okay, when I'm standing, who plays a bigger role? It will be maybe four of them, but when I'm swimming per se, okay. So, for example, if I'm swimming, so who plays a bigger role? Is it my muscular system, modulator system, biomechanical support, all of that? Okay, in each sport, so each movement that we are doing, all of these four systems needs to contribute the equal amount of support in order for us to have a good movement, like what is mentioned here, a precise movement, and also eventually we have a good musculoskeletal health. Okay, all of these four systems. Okay, again, if you look into the next page of my slides, okay, now here I'm broadening it up a bit based on our functional. Okay, the same support system, your base, your modulator, your biomechanical, and support. Okay, if there's an injury, there will be an impairment of component. If one of the support system is not doing its job, let's say if the modulator systems, okay, my nervous system is not giving me the correct input, okay, it does not give me a correct input, eventually it cannot produce a correct output of muscle contraction. Okay, again, the possibility of injury will be there because there will be an impairment of that components. I will have an issue with muscle contraction. Eventually there will be a movement impairment. Once there is a movement impairment, again, certain functions will be limited. Okay, when we can't correct that certain functions, okay, That limitation will eventually cause us to have a disability. And this is by far not only towards sports people. Please do understand that I am here talking not about sports population only. Okay? We are talking about our normal populations, regardless, young, middle age, old, regardless of age, we are treating the same person. And with this pathokinesiologic model, we can use this particular model to see every population of our clients, right? Again, the next kinesiopathological model would be, the next one will be our kinesiopathological model, okay? So what are the biggest differences? The pathological model was slightly older, okay? Comes to a kinesiopathological model, the name has been updated. However, the basic component still remains. Okay, so when one component of human movement system is not functioning optimally, okay, a secondary effects may emerge. Again, the definition with the previous model is similar. So when there is a problem with one system, one movement system, there will be a predictable pattern of dysfunctions that we see, and very likely some of you all may have seen it. Okay, maybe some of my students have seen it in the clinics, or maybe some of your all therapists, my fellow alumni, and also all the lecturers and any clinician out there, you may have seen a predictable pattern. Okay, when a person is having a hip injury, you might predict like, oh, possibility you might have a shoulder injury, maybe, right? So with this, we just don't know what to do with it. Okay, we don't know how to create a relationship between these two. Okay, with a given of time, with a given of an open mind and a little bit of training and a little bit of knowledge, we can actually have empowerment to our clients and making everybody move better, right? So under these kinesiopathological models, we have few components, okay? Reciprocal inhibitions, synergistic dominance, arthrokinetic inhibitions, relative flexibility, and pattern overload, right? So these are some of the terms that may not be layman as possible, but it can be very useful to clinicians. Okay. So if you look into the kinesiopathological models, we are looking into one kinetic chain. No movement is isolated. Okay. No movement is produced by a single joint, right? So there are multiple systems. Here we are again defining it more with a kinetic chain is being produced by a myofascial, or it is controlled by our myofascials, our articulars, which is our joints, and our neural, which is our nervous systems. Okay, so nervous systems, all these three things will create a good sensory motor integration. Okay, we need to sense our environment in order to produce an output. Correct? With this, if there is any problem with one of these three, there will be an issue with our sensory motor integration. If I have issue with my balance, my ears couldn't define what is flat, what is slope, eventually there will be an issue with my myofascial and articulars. Or they will try to adapt to it, eventually creates a compensatory movement. Eventually, my sensory motor integration will be screwed. Okay, so these produce a neuromuscular control, right? And again, how does a dysfunction leads to injury? So by looking into this a little bit in depth, okay, with this particular concept or approaches, I hope you can understand or link up how does a dysfunction leads to an injury. Because we need to understand that movement compensation is something that we cannot deny that everyone have, right? everyone has movement dysfunction. Okay, whether does it creates pain or not, that is relatively a different story, right? So dysfunction itself, okay, if we have an altered length tension relationship of our muscles, maybe my bicep is tight and then my triceps is weak per se. Okay, that will be one of the problem. An altered force couple relationship. Okay, again, easy. Another easy method to say what is a force couple relationship is that my brain favors one movement in particular compared to the others. Okay, altered arthrokinematics would be if there's any issues with my arthrokinematics, which is my movements inside the joints, right? Whether it roll, whether it glides, right? So altered sensory motor integration, all of these people, if there is any issue with these three musketeers, okay, there will be an issue anything downstream. Okay, altered sensory motor integrations, you have an altered neuromuscular efficiencies. With that, our movement will be incorrect. If you look back into the previous pathology model, if you look into this, movement impairments, okay, that is where we're going to see similar thing. Movement impairments will be here, and then there will be a tissue fatigue, right? When that tissue goes into a fatigue, there is much more time is needed for recovery rate. However, because our movement is already impaired, the tissue will not rest. Eventually, it creates or it initiates a injury cycle. So this will cause a vicious cycles for our injuries. Again, what is happening with chronic injuries? Similar, because people don't create a new pathway or create a proper movements for them to for the tissue to create a good environment that it actually can heal, right? So recovery is important again, right? Again, so where do we step in as a physiotherapist? Okay, so we step in as a physiotherapist from the initial point itself, from the top. Then we create a good environment which can actually prevent injuries and we actually can heal injuries, right? So here I'm gonna explain a little bit what is reciprocal inhibition. Okay, always remember reciprocal inhibition is in the terminologies where we see mostly in neurology. Okay, reciprocal inhibition in our proprioceptive neuromuscular facilitation. Just remember one thing: when one goes up, one must come down. So when one muscle contract, one must relax, right? So if in a resting position, when one muscle does not relax, or maybe one muscle is so tight that it is in a constant active mode, what's going to happen to the opposite muscle? There will be a compensation. Okay, there will be a compensation. There will also be a impairment, right? Synergistic dominance. So reciprocal inhibition will create a synergistic dominance. Okay? So when we look at this, occurs when synergists and stabilizer muscles compensate for a primary movers during a specific movement patterns. So let's look into my bicep again. If my bicep is not strong enough, or maybe my tricep is overactive, so I need to create a stronger pull for myself to bend my elbow. So now my bicep is not doing so much of work because it has been overcompensated or over dominated by my tricep. So my brain will eventually load up my brachioradialis. So it creates a tension pull first so that my bicep can work. So what's happening here is my prime mover is not doing its job. So my synergist muscle needs to do the job. Eventually, that synergist will take over the prime movers, which become synergist dominant, right? And this is very common that we see in walking also. When our hip flex or when our hip extensor is not doing its job, we will try to arch our back so that we cheat our way with a hip extension by doing a back extension, right? Probably you can try to visualize it out. Maybe you can come to MAHSA University and look about it, right? Atriokinematic inhibition, this is a very clear and a very direct component. Okay, there is a dysfunction within my joints. It does not glide, it does not roll. Eventually it creates an abnormal movement for my muscles. So either my muscles need to pull more, either it needs to shorten a little bit more, or either it needs to lengthen a little bit more. So what happens here? Lacking movement between the joints will reduce the efficiency of my muscular contractions. Eventually, it will cause a compensatory patterns, which leads to a movement dysfunction at the end of the day. Okay, so if I ask one of you, or maybe usually I ask my students when I'm teaching, guess who has the best squatting form? Okay, and most of them will get the wrong answers. Okay, it is actually toddlers. Okay, babies actually have the best squatting formation because most of their joints are still soft, so they can create a good opening of the hips, and they have good range of motion on their ankles, and they can stay in that position for quite some time. So for this, I will give you a memes. Did you do your squats today? Right? So squats is a good exercises. Don't get me wrong. It is not bad for your hips or your knees. Do it properly, load it properly. You will get a good result. Okay. Relative flexibility. Our body will always take the path of least resistance. So don't underestimate our body. Okay. Your body will always try to find a shortcut to perform something with least resistance. Okay, our body itself does not like resistance, so it will try to find a way. It will try to find a movement which cuts away that resistance. Okay, it is a subconscious response. Okay, it is not something that you think about. I couldn't perform my movement towards this way, but my body will say that, oh, this way is much more easier, right? Hence, compensation is relatively normal. As I mentioned earlier, compensation is relatively normal. Okay, don't deny that. We can't deny that. But what our job is, or what we can do is to optimize our movement so that it creates a healthy environment for our joints and reduce much injury as possible. And the last one will be pattern overload. Okay, and this can be correlated with almost everyone that is playing sports, relatively elites or maybe a weekend warriors. You tend to experience this because you'll be doing that particular movement patterns repeatedly. Okay, by doing that repeated movements, you will create an overloading response to the muscles. Okay, eventually tissue gets overloaded, tissue gets fatigued, and that's where injury comes in. So when you trace it back, what is the main problem? Is it the movement, or is it the tissue that get injured is the problem? It's the movement. It's the pattern of the movement, right? So here, I just want to let you all see or let you all open up your mind. There are common patterns of dynamic movements, okay? So you have a spiral chain dynamic movements. You have a vertical static muscle chains, okay? And what you will see is you need to look into both types of movement chains, okay? When you're treating your clients, like what are the most common spots or the most popular sports nowadays. Spin class, okay? Spin class are very popular. You have fly cycles, you have previously Ministry of Burn, you have Powerhouse right now. right? And then vertical static muscle chain, you have those who does a little bit of bodybuildings. At times they need to do a lot of static movements. Okay, so these are the movement patterns that we see every day in our life. And even though as a normal person, when we are walking, we are utilizing a lot of our dynamic muscle chain, our spiral movements, right? Our spiral patterns. Okay. So with that, at the end of the day, how do we deal with movement dysfunction? So that's the main topic of what we are dealing with today. Okay. Again, you need to understand that there are no specific treatment or approaches in treating movement dysfunctions. However, there are something that you can do in order to open up your mind to understand, like, oh, I can treat movement dysfunction this way. Okay, there are no specific approaches, right? Keep in mind that treating movement dysfunctions, we also need to treat it with movements, right? A movement problem, treat it with a movement. However, you create a movement which is healthier, right? So the first thing that we need to identify is identify the causative factors, what caused that movement dysfunction, correct the weak links, okay, and then recondition. Okay, when you look into these three particular points, it is very, very closely related to our motor relearning program in neurological approaches. Find the missing component, practice the missing component, and so on. Okay, variabilities of trainings and so on. Okay, similar things. Okay, the only differences, it is not a missing component but the weakest link. Okay, so how do we identify these links? So but how can we identify this link is that we usually utilize posture as our assessment, gait flexibility assessment, neuromuscular assessment, overhead squat test, multiplanar vertical, multiplanar horizontal, jump hop, single leg squat, multiplanar lunges, multiplanar step up test, push up test, and overhead medicine ball throw. And there are actually a lot more. But on simple terms, we just go ahead with an overhead squat test. Okay, you actually can utilize as a simple movement as possible, and sit to stand, we also can perform it. Okay, in elderly, we will always try to double check or try to assess the sit to stand, whether they are leaning to one side or not. Right? Right. So transitional movement assessment, basically we are performing a movement assessment while moving. Right. So when you look into this particular, let me take my laser pointer, right? So when you're asking someone to do an overhead test, all right, what we can see or what we are trying to see is the ability of this particular client to stabilize each joint, and we can see or we can find out where our missing link is or where our weak link is, right? So we can look into the integrity of our foot and ankle imbalance, our hip, and knee imbalance, okay, our hip and pelvic imbalance, which this imbalance will create an imbalance to our shoulders also. Okay, so this is what we are looking at: our knees and hips, our ankles and foot, our hip and also our pelvic together. All right. So from the sides, we can look whether this particular person will arch their back a little bit too much. Okay. From the back, we actually can identify whether this particular client is leaning more towards the right or towards the left. Okay. We want to see whether the knees are caving in. Right. With this, we can identify the weak links. However, most of what we do is an educated guess. With that educated guess, we eventually then create or address or assess it scrutinously. Okay, So overhead squat position, we were able to address or identify kinetic chain, okay, imbalance at the feet, knees, hip, spine, shoulders, and head, right? So when you look into this particular clients, okay, so we can address whether the knee is slightly caving in. That's the reason why the midline has shifted towards his left side, our right side, okay. And what is the problem here? I'm just making an educated guess or educated assumption that I will assume that he have a poor or weak hip stabilizers, or maybe he have a poor ankle mobility. So what do I do with that educated assumption? I will perform a assessment which is directly linear to the problem, right? Again, educated assumptions, like I mentioned earlier on, right? So when you're doing this particular movement, we are looking into the ability of this patient or this client to have a good parallel movement. Okay. What is the problem when he is or when he or she is performing a movement like this? Okay. There might be a poor ankle range of motion or flexibility, which doesn't allow the knee to cross path beyond the toe level. Eventually, it creates a high leaning, okay, an extra leaning forward position. Again, the probability of these particular clients to have a back pain or knee pain may be higher. All right. So these are the movement dysfunctions. Testings. Okay, single leg squat. We are not doing a pistol squat, but however, we are doing just a mini single leg squats. Okay, with this, we can identify whether the hip, ankle, and knee can actually perform a movement in a unit as a single unit and not isolated. All right. So, as I mentioned previously, no one movement is a single oriented. It will be a group oriented movement. Right. So, identification of multiplanar imbalance. Again, weak links, we need to see it based on our sagittal plane, transverse plane, frontal plane, and horizontal plane. With this, per se, what if the shoulder is actually pointing this way? Then we might have a rotational issue. Maybe the pelvic is rotated, which brings it up, which brings the whole pelvic towards this way, which caused the shoulder to move that way. So when he or she is performing a certain movement, let's say lifting up a dumbbell or maybe lifting up the daughter or a son, they might have a pinched shoulder. Okay, but how do we identify that? With this particular movement. Okay, again, what if is the shoulder is pointing forward? That would be a good thing or a bad thing. Can be a good thing, it can be a bad thing. All right, so a compensation is vital. Sometimes it is necessary, sometimes it is not. Okay, so what do I do with this information? As I've mentioned previously also, once you get this information based on that screening of movements, that educated assumptions, you will utilize your normal standard protocol assessment. However, your assessment is more linear to the goal of the patient. It is very directed, it is very goal oriented, right? Because we know what movement is causing the problem. And we are trying to find the root cause of the problem. So eventually, our clinical reasonings are linear towards the root cause. All right. With all of this information, when you gather it around, we will create a storyline which makes more sense. Right? So because the problem with the current trending of physiotherapy practice in Malaysia, that what I've seen and what most of my colleagues have said, and maybe the students have given a feedbacks, is that most of the assessment are very isolated. When you have a knee pain, you look into just the knee. Always remember that we want to create a healthy community. Treat the person and not the condition, right? So what is our solution? Again, as I mentioned previously, there is no one direct solution. By performing an integrated approaches, we can actually create a better environment and empower all of our clients. So one of the solution concept is to manage the weak links. So with this management of the weak links, we can also create a lot of good behaviors. What I mean by good behaviors is a good behaviors towards the muscles, right? By empowering our clients and empowering our self body, okay, we always must, again, I always believe that as a physiotherapist, we ourselves need to move or to feel that particular exercise before prescribing it to the patient. Okay? So that we understand, oh, this is the difficulty that they might have. Okay. So the first thing is an integrated exercise. We need to create a good environment. So the sole purpose of a physiotherapy in managing movement dysfunction is correcting muscle imbalance and also create a good environment for the muscle to heal or for the soft tissue to move, right? Inhibit overactive muscles by performing our massage, maybe our soft tissue manipulation, or maybe our trigger point release. You can also use your dry needlings, right, and your massage guns. Lengthening the overactive muscles, we can perform our passive and active stretching, which can be which one that you most likely are comfortable with, all right? And active the underactive muscles, we can utilize our approaches such as our PNF, okay, dynamic reversals. You can also utilize your rhythmic initiations, okay, by doing an isometric contraction such as a minimal contraction. However, we gradually increase it, the range, also create a good environment for the underactive muscles to get more activated, okay, and always and always and always integrate that particular exercise into a functional movement patterns. Do not, I would say, try not to isolate that particular exercise too long. Always integrate it with movement, functional movement patterns like squats, lunges, performing a push. Maybe you can ask the client to push a heavy trolley, right? Or pull a heavy trolley, a hinge movement, a twisting, which involve a lot of rotation. Our daily activity involves a lot of rotations. When you're walking from, when I get up from this chair to go to the toilet, it involves hinge. It involves hinge. It involves a little bit of squats, reverse of the squat, where I'm going back up, right? And hinge and gates. Okay, twisting. When you're walking, it's a twist movement itself, right? So with that, this will be my last slides. Okay, I hope that I've shared most of my most of what I want to share, and I hope it actually correlates with your daily life, right? And I hope it empowers our future students to be a better therapist than, and also even if you are already good, be better. And even if you are the best, let's say we are the best, we will always try to be better, correct? So by having a little bit of knowledge and an open mind, take everything in a grain of salt. Even what I'm saying today, take it with a bit of a grain of salt, understanding it a little by little, then you can create a better outcomes. Okay, so we need to appreciate movement as a whole and not as an isolated out movements. Okay, always appreciate a movement as a whole. Okay, choose movement patterns which is at utmost functional for your clients. Okay, if I have an issue with uh, if I have an issue with reaching forwards, utilize that forward reaching movement in your exercise. Always put your exercises or your management into the context of the patient's goal. Load our clients progressively. And another one thing that I have seen in in our current practice is we tend to underload our patient, chronically underload our patient. We don't load our patient enough progressively. Don't don't be scared to pick up a little bit of weights. Okay, increase when we increase the tissue capacity so that the tissue capacity will able to handle a certain amount of load, and that's what we want. Okay, we want to increase the tissue capacity so that we can create a better and more healthy and a stronger joints, right? Okay, don't negate or don't let's not try to underestimate stress. By giving a good amount of stress, we will actually create a stronger body, right? And that's all for me today. And I'll get back to Mr. Kausa again.
Okay, thank you, Mr. Bannister, for the insightful presentation. Dear viewers, if you have any question for Mr. Bannister, please leave a comment. Please fill in the survey form, which can be found at the comment section by the end of this webinar. Each set will be awarded. Right now, currently, we are waiting for question from audience. Okay, so far we don't got any question. Actually, I got one question. Is this what are the biggest limitation for this approach, and is it limited only for musculoskeletal condition?
Okay, basically this particular approach it is not limited to musculoskeletal condition, but it is heavily emphasized in musculoskeletal condition. If you ask me about whether what is the biggest limitation, I would say it's ourselves. We ourselves is the limitation. We are limit. Our knowledge is limited. Hence, this approach will be seem like it is limiting us. Right?
Okay, thank you, Mr. Banyisa, for the
Hi.
very
No problem.
very detailed explanation. Okay, so we have okay, okay. Right now we got one question from audience. It's from Azalina Suzianti. What causes the movement dysfunction?
Hi, Azalina. So there is no there is no one definite answer that is causing movement dysfunction. It takes up a amount of time to create a movement dysfunction. Okay, it is non-specific. Let's say, for example, your ankle sprain 3 months ago may cause you to have a lower back pain today. But as me as a therapist looking at you today, you will tell me that you have a lower back pain. So distinctively, I will tell you that okay, you will have a back pain. That's why I will treat your back pain, but I neglect your ankles. However, that will create a cumulative vicious cycle again. Right? So there is no definite answer what causes movement dysfunctions.
Okay, so actually I got one more question. Okay, what are your thought on the current practice in Malaysia so far?
So the current practice in Malaysia, to be honest, when I've been around in the scene with with physiotherapists also. In the private, I don't think that I don't think it's a issue. Okay, because most of the private centers are creating a very good movement with themselves. They create a good, and each of the therapists are actually joining a certain amount of classes like weightlifting classes. So they are in depth into that particular population that they are looking at. Okay. However, in the government sector, okay, I couldn't blame so much because the amount of patients that they are looking at is too much. However, one thing that I hope to see in the government is that because in the government we tend to chronically underload our patient, we tend to not progress them in a correct manner. Although systematically we should progress in this manner, however, the client or the patient does not follow that periodically systemic manner. Okay, so that is one of the biggest problem I see in Malaysia itself. However, I don't deny that we are trying, and it is always better each year.
Okay. Thank you so much, Mr. Bannister, for the very detailed explanation. Okay, we have come to the end of the today's session. Thank you, Mr. Bannister, for joining us today and providing such insightful information. To our wonderful audience, thank you for joining us at this webinar. We look forward to your comments and participation at future events hosted by MAHSA University. Okay. In case of any further queries, you can contact us through MAHSA website or visit our social media. Thank you so much. Have a pleasant weekend and happy Chinese New Year. Thank you.
Yeah.
Assalamualaikum.